So for example, in this particular image is already projected in your screen, at first glance it may look normal, but actually one of the more early infarct sign is demonstrated by the arrow, which is the hypodensity, relative hypodensity of the lentiform nucleus on the left compared to the right side. And this is actually the obscuration of the lentiform nucleus sign. So one of the early infarct signs that we'll look for would be the loss of gray-white matter differentiation. This could be very subtle, but once you already have the clinical picture of the patient and you are suspecting an infarct in certain areas, you would have to look for this sign in the probable areas of involvement. So for example, this patient, an 85-year-old male presenting with right-sided weakness. So for us radiologists, it is very, very helpful if the clinicians would be providing us with the neurologic exam. This is not to be for us to be biased with our reading, but this will also really guide us as to where to look at um, in diagnosing these patients. So for this patient, a CT scan was obtained. This particular axial cut that is taken at the level of the body of the lateral ventricles, you don't really see any frank abnormality when comparing the right side of the brain to the left side of the brain. But as we go further down, here you can see that compared to the right side, the insular cortex appear hypodense. And this is one of the early infarct signs, which we call the loss of the insular ribbon sign. So this is one of the early infarct sign that is due to the increase in the relative water concentration within the ischemic tissues that is specifically more marked in the gray matter. So this is the reason why there would be obscuration now of the gray and white matter interface. Another patient, a 58-year-old female. I purposely did not put the side affected, but this patient presents with hemiparesis. Again, in this particular image that is being projected in your screen, the sign of infarction is very subtle. Although, of course, we can already see that there is quite more hypodense appearance on the left frontal lobe. And this, as we go further down, as we evaluate the cortex, because as I've said, infarction affects both the cortex and, of course, the white matter. And as we evaluate the cortex, we can see that it extends into the cortex, that hypodensity, even in the more inferior images. Again, demonstrated here is the loss of the insular ribbon sign, the hypodensity in the insula as pointed by the arrows, as well as the hypodensity in the lentiform nucleus on the left side. So again, another lenticular obscuration or disappearing basal ganglia sign of early infarction. Okay, so aside from demonstrating the presence of infarct, we also would want to see the extent of infarct. Okay, because in the earlier studies, more extensive involvement of the brain actually would mean a poorer prognosis to the patient and also poorer response to treatment and sometimes greater risk of hemorrhagic conversion if thrombolysis would be instituted. This is because when there is a large ischemic lesion, there would be insult in the vasculature, and once this injured vasculature is reperfused, there would be disruption of the blood-brain barrier that may lead to hemorrhagic transformation in what we call reperfusion injury. And so, because it's really hard to estimate whether more than 1/3 of the vascular territory is involved, there are scientists in Calgary that developed this Alberta Stroke Program Early CT Score, or aspects, in estimating the extent of infarction, particularly in the middle cerebral artery territory. So this entails evaluation of two standardized regions of the MCA territory at the basal ganglia level and at the supraganglionic level. So, as I've said, there would be particular areas in the MCA that we will be evaluating for the presence of infarction. Okay, I'm sorry for the confusion in the slides, but let me go back to that particular slide demonstrating that. Okay, so for the ganglionic level, the structures that we will evaluate for the presence of um, infarct signs would be the caudate nucleus, the insular ribbon, the internal capsule, the lentiform nucleus, as well as the more peripheral cortical areas of the MCA at this level that is labeled M1, M2, and M3 as you can see in the screen. As we go further up at the supraganglionic level, we again assess for these cortical areas labeled M4, M5, and M6. How do we evaluate aspects? We have to remember that you do not just get two representative cuts for the ganglionic and supraganglionic structures. We have to evaluate all cuts wherein we can still see the structures to determine if an area is indeed involved. And it should be a practice that before you could really say that there's an abnormality, this abnormality should be visible on at least two consecutive cuts to ensure that this is not just due to some artifacts or the volume averaging effect. So how do we compute for the aspects? Again, we look at those particular structures and areas in the MCA territory, and involvement of any of those would be subtracted to 10. Okay? So, and then the total score after you have subtracted all the areas that is involved in the infarction would be your aspect score. So just for example, if there is diffuse involvement throughout the MCA territory, meaning all those 10 structures or areas has ischemic signs by CT scan, the score would be 0. So just to give you an example of how we do aspects, so this is a particular um, cut of the brain, axial cut of the brain in the level of the basal ganglia. Okay, so the ganglionic level. Here we can see the loss of insular ribbon sign on the left side. And there's also the obscuration of the lentiform nucleus sign also on the left side because the involved um, uh, territory would be the left MCA. Now, in this particular cut, we can see the caudate head. And when we compare the left caudate head to the right, it seems that it's not involved. And so this is where I would want again to emphasize that you have to assess all cuts wherein you can still see the structure before you can say if it's involved or not involved. Because as you can see, as we go further up, the caudate nucleus already appears hypodense. And so it is also involved in the infarction. There's also suspicious hypodensity at the supraganglionic level um, at the region of the M5, but we are not certain whether it also would involve the cortex. And so in this particular scenarios, what you can do is actually go or ask the help of your radiologist to window the examination to a narrow window width and length. Personally, what I use is this window setting because it actually highlights the hypodensity or the hypoattenuation in the brain secondary to infarction. And so in that equivocal involvement of M5 in the previous image, as you can see, once you window it, it can be more um, it is more what do you call this, it's more definite. And so this narrow window actually increases the sensitivity of detecting ischemic changes from 57% to 71%. And so as we go further up, we can see that indeed that particular particular area extends into the cortex, and hence there is really involvement of the M5 area. How about that that small area, cortical subcortical hypodensity in the M4 region? We also scored aspect. I mean, we also give 1 point for that to be subtracted in the aspect score. And again, in the supraganglionic level, I know there's the body of the nucleus of the caudate nucleus is where you can see this particular structure in supraganglionic level, and indeed, caudate nucleus is involved in this um, left MCA infarction. And so to just compute the final aspect, as I've said, from 10, you subtract all the areas um, that are involved. So for this particular patient, 5 areas are involved, and so the aspects would be 5. And what does this mean? Okay, has been said that aspect scores of 6 or less, meaning there's more extensive cerebral hypoattenuation, it is correlated with both poor functional outcome and symptomatic intracerebral hemorrhage. For those with scores 7 or more, these may be the patients that will have greater extent of benefit from thrombolysis and thrombectomy. So this applies for both thrombolysis and thrombectomy. Okay, so we are done with the early infarct sign of loss of gray white matter differentiation. Another early infarct sign would be the increased density of the vessel, and this will include the hyperdense MCA sign, the MCA dot sign, and the hyperdense vascular tip sign. These signs are actually seen in the CT scan as a representative, or really the direct visualization of the thromboembolic material within the lumen of these vessels. So for large artery occlusion, typically these are result of embolization of atherosclerotic debris from more proximal larger vessels, including the common carotid and internal carotid arteries, or even from cardiac source. And since these clots already had time to retract in these more proximal sources, once it becomes uh, embolic into the smaller intracranial vessels, they will already appear hyperdense, hence giving you this increased density of the vessel sign. Recently, there were also studies that said that if you see this increased densities of the vessel sign, um, more likely the content of the clot, or the characteristic content of the clot, would be erythrocyte rich. And they say that erythrocyte-rich clots are actually easier to retrieve by thrombectomy compared to fibrin-rich clots, which will not present with increased density of the vessel size. So, projected in these slides would be the scenarios wherein you may not appreciate the increased density of the vessel sign, even if there is a ischemic stroke present. So, in the event that there is inside the thrombosis, because the clot may still not be fully retracted, also very common scenario for Asian population would be intracranial artery stenosis. So because there would be no clot there, you of course would not see this increased density of the vessel sign. And as I have already mentioned, fibrin-rich clots usually do not also present with this CT sign. Okay, so just to give you representative images of how this increased density of the vessel sign. So the most common, the hyperdense MCA sign. As you can see, the hyperdense, or the white appearance of the left MCA, M1 segment, particularly the M1 segment, which corresponds to the thrombus in that vascular segment. Now, the MCA dot sign is just actually a cross-sectional M2 equivalent of the hyperdense MCA sign, and the affectation would be, as I've mentioned, the M2 segment. This is associated with better outcome than the hyperdense MCA sign because, of course, it involves the more distal vessel, and hence also the arterial the areas supplied by this vessel may be smaller compared to the more proximal vessels. This is also known as the Sylvian Fisher sign. with very characteristic clinical features is the top of the hyperdense vascular tip site that can be seen in the top of the basilar artery syndrome. So this is a true neurointerventional emergency, and hence, if you are highly suspecting this clinically, we also have to pursue looking into a possible CT sign, which is the hyperdense vascular tip sign. So that case is actually confirmed from with a CT angiography of the patient. Now, there are limitations to non-enhanced CT scans, and one of those would be the presence of motion artifacts. So this is a patient, unfortunately, of course, our stroke patients, most of them would be agitated or disoriented and not able to really follow commands. So many would present with motion artifacts in CT scan, and this can actually really affect also your evaluation because there might be an overestimation of the hypodensity secondary to the presence of these motion artifacts. Another limitation would be the presence of leukaryosis or the white matter changes, because it would be very hard really to distinguish this from changes or infarction, especially if the infarction would be small and be involving the deeper um, parts of the cerebrum. Okay, so we are done with CT scan. We now proceed to MRI in the evaluation of the brain parenchyma. So just like CT scan, MRI is also deemed effective in excluding ICH or intracranial hemorrhage before IV alteplase administration. Dr. Lagamayo would be discussing intracranial hemorrhage in depth, but just to give you a brief overview of how intracranial hemorrhage would look like, because again, this is the first thing that we would want to exclude in suspected ischemic stroke patients, because it is an absolute contraindication to thrombolysis. So for non-contrast CT, as I have mentioned, it would appear hyperdense or white in the brain parenchyma. For MRI, of course, magnetic resonance imaging, the difference from CT is you have different sequences to look for and interpret. But for hemorrhage, what is important, the primary sequence that you would have to look at is the gradient recall echo or the susceptibility weighted images, which is the one sensitive in detecting blood products. So for acute intraparenchymal hemorrhage, it will not really appear blooming dark immediately. What you would see is actually a an iso-intense collection in the brain with a rim of hypodensity or susceptibility signal. So you have to remember that for the hyperacute to acute hemorrhage, it will not look like it will not present with that blooming dark signal on GRA and SWI. One advantage of MRI is its ability actually to detect chronic microbleeds. So these are virtually invisible in CT scan. These are not absolute contraindications to thrombolysis, the presence of which, but it has been said that if you detect more than 10 chronic microbleeds in GRE and SWI sequences of MRI, there might be an increased risk of symptomatic intracranial hemorrhage after thrombolysis. So the WI, okay, so we have discussed already that particular sequence that is sensitive for hemorrhage. Now, for ischemic infarct, you have to remember this sequence. It's the diffusion weighted image or the DWI. So this is interpreted or always interpreted side by side with an ADC map. Okay, this particular sequences has emerged as the most sensitive and specific imaging technique for acute infarct. It can detect about 95% of hyperacute infarcts on DWI. And another advantage is that it can actually distinguish acute from chronic ischemia. Okay, so there may be new lesions that is located in the proximity of a prior ischemic injury, which you cannot anymore delineate using CT, but cranial MRI, particularly the diffusion weighted image, will be able to map out that involved area. So, as I have said, a pitfall of CT scan would be the presence of white matter changes. DWI will also help you distinguish infarcts from just microvascular ischemic changes or white matter hyperintensities. So just to give you a brief overview of how the signal of infarct comes about in DWI. So in the normal state, okay, as you can see here in the screen, there would be the extracellular space and there would be the cells in that particular compartment. And in the normal state, water would actually move freely in the extracellular space. But with ischemia, there would be injury in the sodium and potassium pump in the cell membrane. And this will actually cause influx of water from the extracellular space into the intracellular space, resulting in cell swelling. And these swollen cells will actually contract the extracellular space, and hence the term restricted diffusion, because there would be significant decrease in the movement of water in the extracellular space. This is the one responsible giving that bright signal on DWI. So, as I already mentioned, ischemia infarct would appear bright on DWI with corresponding hypointensity on the ABC map. Okay, so this is 4 to 5 times more sensitive in detecting ischemia compared to non-enhanced CT. And another advantage is its ability to detect the infarcted region at very early time points. Within minutes, this will already be depicted on DWI. Just to emphasize that, this is a patient, 35-year-old male, presenting with hemiparesis and neglect. Okay, again, I purposely did not put the side just to demonstrate to you that it's really very hard to um, zero in a particular abnormality in CT in the very early stages of ischemic infarct. So for this patient, the involved areas is equivocal. There is a suspicious hypodensity actually noted at the left frontal lobe. And so it was fortunate that the facility where this patient was brought to had already also has an MRI, and so they did an MRI right after the CT scan, and within just a span of, a difference of 30 minutes of transporting the patient and doing the scan, this diffusion weighted image clearly demonstrate the involvement of the, I'm sorry, it's in the right, not the left, the involvement of the right MCA territory for this patient. So again, this just demonstrates the higher sensitivity of DWI compared to CT scan. Okay. Another advantage is that it can detect relatively small cortical, deep or subcortical lesions, or the lacunar infarcts. You cannot see this, the acute lacunar infarcts on CT scan. And as we know, it is also more sensitive in demonstrating infarcts in the brainstem and cerebellum, which can be obscured by beam hardening artifacts in CT scan. Okay, just an example, normal looking CT scan on your left side, but on DWI, you can see that small, bright signal focus on the right thalamus, which is actually an acute lacunar infarct. For same, this is a patient presenting with dizziness, and the CT quality is really bad, especially in the posterior fossa because of the presence of these osseous structures in the skull base, and you cannot really evaluate the brainstem properly. And when they did the DWI, it clearly demonstrates the acute infarct in the right hemipons. Okay. Another lesion lesion in the brainstem, particularly at the level of the medulla. So this is a DWI and its corresponding ADC map. The hyperintensity in DWI is equivocal. I mean, it's not really the light bulb bright characteristic of infarcts. And so when we do our PAD protocol, so particularly if we have suspected stroke patients, we have a dedicated protocol for scanning and MRI. Usually it will just include an HLDWI ADC, but in cases wherein there's equivocal findings, I mean, you cannot really commit, is this really restricted diffusion? It helps to do an additional coronal DWA-ADC. As you can see in this particular case, the coronal DWA-ADC clearly demonstrates the acute infarct in the right lateral medulla, especially for lesions in the posterior fossa. And the findings is equivocal in the HLDWA-ADC. It may be beneficial to add on a coronal sequence. The scanning time added is actually, I think, less than 2 minutes for both. I mean, for this coronal sequence, and um, it will really help you determine whether there is presence of infarct, especially in the posterior fossa. Another advantage of using MRI as your imaging modality for the evaluation of ischemic stroke would be for those who has this wake up stroke. So it has been defined, wake up stroke is defined as um, those patients who has a known time of symptom onset, and it actually comprises a significant percentage of stroke patients, about 20%. And so this is a relevant number of patients that might benefit from reperfusion. And so MRI will actually help us determine whether they may still be eligible for treatment. Okay, so in patients who awake with stroke symptoms or have unclear time of onset more than 4.5 hours from last known well or baseline state, use of MRI to identify diffusion positive flare and negative lesions can be useful for selecting those who can benefit from thrombolysis within the 4.5 hours of stroke symptom recognition. So what we are looking for would be a DWI flare mismatch, meaning there is already restricted diffusion or bright signal changes on DWI, but on flare, on the corresponding flare image, you cannot definitely see the corresponding hyperintense signal or abnormality. So this is an imaging surrogate, the marker that again may identify patients likely still within the 4.5 hours stroke onset and may still be eligible for thrombolysis. So, just an example, this is a 64-year-old male patient with right-sided weakness and numbness, presenting with definite restricted diffusion in the left posterior parietal lobe, but on flare, there's still no demonstrable corresponding hyperintensity. And so this patient may still be eligible for thrombolysis or may still be within that 4.5 hours from stroke symptom onset. Okay. What are the limitations for cranial MRI? Of course, it's more costly. Again, not all hospitals will have an MRI, so there's relatively limited availability. One of um, the important limitation, actually, I mean, one of the limiting factors of MRI is its long duration of scans. There's always fear of decay in the time because of the longer duration of scan of MRI. But I will be discussing how you can actually circumvent that or um, by the use of a dedicated brain attack or stroke protocol. And other patient contraindications, the MRI, you have to still be very careful with screening patients before putting them in the magnet of the MRI because it can be detrimental to the patient if there would be presence of, for example, of cardiac pacemakers or metal implants. Um, about 10% of patients will not be able to remain motionless during the scan, the MRI scan. And so the image quality may also be compromised for these patients. So as I've said, um, the long duration of time should not be a limitation for stroke patients, especially if it's hard for you to diagnose stroke, ischemic infarct by CT scan. What we use in the institution I am affiliated to is this particular protocol for brain attack, comprised of just an axial DWA ADC. Sometimes we request for coronal DWA ADC for equivocal lesions, an axial flare, axial GRE, axial T2 weighted image, and as I have already mentioned in the first part of my lecture, evaluation of the vessel is also very important. So we do a time of flight, MR angiography, both of the intracranial and the neck vessels. Okay, so we are done with the parenchyma. We are now going to proceed with pipe or the vascular evaluation. The gold standard would still be digital subtraction angiography. However, for ischemic stroke patients, because it is time consuming, um, this is actually not the recommended vascular imaging for our patients. So the recommendation is the utilization of a non-invasive vessel imaging, especially for patients suspected with large vessel occlusion, and should be obtained as quickly as possible. So our options would include the request of CT angiography, which is very sensitive for intracranial occlusion and stenosis, both for intracranial and extracranial occlusions and stenosis. So, an example with this patient with right hemiplegia and aphasia, and when we window the patient, that particular axial cut, we see hypodensity in the left frontal lobe. The hyperdense vessel is quite equivocal because although the M1 left M1 segment appears um, more hyperdense compared to the right, it's still very hard to call. And so they did a CTA for this patient, and the CTA confirmed the cutoff in the M1 segment of the left MCA because of the presence of thrombus or occlusion. Um, this patient was eligible for thrombectomy, and on the digital subtraction angiogram done before retrieval, there is again demonstration of the cutoff in the left M1 segment. For MRI, what we utilize is the time of flight image. The advantage of this particular imaging technique is that it does not need contrast for you to be able to visualize the intracranial and extracranial vessel. Okay, but the, the disadvantage is that this is only reliable if the involvement would be the proximal large vessels. The TOF sequence actually tend to overestimate stenosis. So for the more distal, the smaller vessels, sometimes even if it's not totally included, it will not show any signal already in the time of flight imaging. But then again, for the purpose of ischemic infarct and specifically for evaluating whether the patient would be eligible for thrombectomy, what you want to know is the involvement of the large vessel. So 3D time of flight imaging would suffice for that. So the disadvantages, again, susceptibility to motion artifacts, and as I have mentioned, its tendency to overestimate the degree of stenosis. So this is a example of an MRA time of flight showing cutoff in the right M1 segment, and just to demonstrate its tendency to overestimate stenosis or not really depict the smaller vessels, a CTA that was done in this patient shows still, of course, the occlusion in the M1 segment, but it also shows the backfilling of the more distal vessels from collaterals, which is not depicted in the time of flight image.
Okay,
Okay,
so
so as I
as
have
I have
mentioned,
mentioned,
in
in our
our
protocol,
protocol,
we
we
include the neck,
include the neck,
okay,
okay,
and
it's
also the
also the
vertebral
vertebral
arteries,
arteries
because
because
this
this
evaluation
evaluation
of
of
this
this extracranial
extracranial
vessels
vessels
may
may
also
also
be
helpful in
helpful in
determining the
determining the
eligibility of the
eligibility
patient
of
and
the
also
patient and
in the
also for
vascular
in the vascular
procedural
procedural
planning.
planning.
Okay,
Okay.
so
So
if you are
if you are
contemplating doing
contemplating
IV
doing IV
alteplase,
alteplase,
it is
it is
recommended
recommended
that
that
or
or
CT or
CT or
MRI,
MRI,
CTA and
CTA
MRA
and
will
MRA will
suffice, and
suffice, and
additional
additional
multimodal
multimodal
neuroimaging or the more
neuroimaging or the more
advanced
advanced
neuroimaging
imaging
techniques
technique
um,
um,
may not be
may
done
not be
so
done
that there
so
would
that there would
not be
not
any
be
undue
any
delay in
undue delay in
initiating the
initiating the
thrombolysis.
thrombolysis.
However,
However,
there is of
there is,
course
of
already
course,
emergence
already
of what we call
emergence
the
of what we call the
physiologic imaging,
physiologic imaging,
wherein
wherein
it actually
it
guides in
actually
the
guides in the
individualized approach
individualized
therapy.
approach therapy.
So
So
this would
this
entail
would entail
assessment of the
assessment of the
penumbra and the
penumbra
core,
and the
and
core
also the
and also the
collateral
collateral
status of the
status of the
patients.
patients. Um,
So for
so for
uh,
uh,
okay, for
okay,
those
for those
presenting in
presenting
the
in the
late third
late
time
third time
windows, so
windows.
this would
So
be
this would be
patients
patients
within the 16
within the
hour or
16-hour
24
or
hour time
24-hour
window.
time windows.
Uh,
Uh,
Assessment of the
assessment
core
of
or
the core or
collaterals is
collaterals
included
is included um,
in determining the
in determining the
eligibility of
eligibility of
patients for
patients for
thrombectomy. Okay, for
thrombectomy. Okay,
thrombectomy. So
for
for this later
thrombectomy. So
time
for this
window,
later time
what
window, what
the treatment option
the
would be
treatment option would
thrombectomy.
be
So the
thrombectomy.
assessment of the
So the
core,
assessment of the
again, just to
core,
give you
again, just to give you a
definition of these
definition of
terms,
these
would be the
terms,
core
would be
would
the core
comprise of
would
the tissue that
comprise
has
of the
already
tissue
been
that has
infarcted.
already been
So it
infarcted.
is
So it is
irrevocably
irrevocably
damaged or
damaged or
it already has
it already
irreversible
has
damage.
irreversible damage.
But what we
But
want to
we
look
what we
at
want
would
to look
be
at would
the
be
extent of the
the
penumbra
extent of the
or
penumbra or
the tissue at least for
the
its
tissue at least for
infarction
its
but still
infarction but
salvageable
still
by
salvageable by
thrombectomy or
thrombectomy or
thrombolysis.
thrombolysis.
So for patients
So
within
for
6 to
patients within
24
6 to
hours,
24 hours,
additional
additional
imaging of
imaging of
CT or MR
CT or
perfusion may
MR
be
perfusion
done
may be done
again to determine
again to determine
eligibility. And this is actually
eligibility. And this is
based on
actually based on
the
the
trials of
trials of
diffuse and
diffuse
also
and
dawn,
also
diffuse 3
dawn,
and dawn,
diffuse 3 and dawn,
wherein they determine
wherein they determine
quantitatively the extent
quantitatively
of
the extent
infarction
of infarction
and also
and
the
also
presence of
the presence of
the ratio between
the
the
ratio
core
between
and the
the core
penumbra
and the
to know
penumbra
if the
to know
patient would
if the
still
patient would
benefit
still
from
benefit from
thrombectomy. So
thrombectomy. So
just some numbers
just
as
some
to
numbers as to
the criteria
the
for
criteria for
eligibility for thrombectomy in
eligibility for
diffuse 3
thrombectomy in
and
diffuse
also
3
the dawn
and
trial
also the
which
dawn
actually also
trial, which actually
correlates
also correlates
the infarct
the
volume
infarct
to
volume
the
to the
clinical
clinical
presentation, particularly
presentation,
the
particularly the
NIHSS score of the
NIHSS
patient.
score of the patient.
And for these
And for
studies, that has
these
been the
studies,
basis
that has
for
been the
the
basis for the
late time windows for
late time
thrombectomy.
windows for
What they
thrombectomy.
use is this
What they use is
automated
this automated
application, which is called
application,
Rapid.
which is called Rapid.
And this
And
particular
this particular
application
application
would determine
would determine
automatically the
automatically the
core infarct
core
as well
infarct
as the
as well
penumbra, and
as
it
the
will
penumbra,
also
and it
already
will also
compute the
already
infarct
compute the
volume,
infarct volume,
quantitative infarct volume,
quantitative
as well as the
infarct volume,
mismatch
as well
ratio,
as the mismatch ratio,
as can you can see in the
as
screen.
can
So
you
this
can
is
see in the
what
screen.
would
So
be
this is what would be um,
given by Rapid, the
given by
application,
Rapid, the
once
application,
you
once you
scan the patient and
scan the
also
patient and
apply the
also
Rapid
apply
application
the
to that
Rapid
scan.
application to that
So it
scan.
would
So it will
automatically give you these
automatically
values
give you
within
these
minutes. They
values
say
within
within
minutes.
three
They
minutes
say
they
within
can give you
three
that
minutes they
so
can
that
give
you
you
get
that
to
so that
a
you get to
decision whether this
a
patient
decision
would be
whether this
eligible
patient
for
would be eligible for
thrombectomy.
thrombectomy.
Another
Another
uh,
uh,
aspect that could be
aspect that could be
assessed for
assessed for
benefit in the
benefit
late time
in
window
the late
would be
time
collateral
window would be
status.
collateral
There would be
status. There would
patients
be
with
patients
large
with
vessel
large
occlusion,
vessel
but when you
occlusion,
look at the
but when you look
imaging,
at the um,
determination of collateral
determination
status,
of collateral
whether
status, whether
this patient has good
this
collateral
patient has good
status and
collateral status
would
and
still benefit
would still
May
benefit
motor.
from
Sabihin ba to?
from uh,
clot retrieval
clot
Ito?
retrieval
to
um,
salvage the
to
penumbra.
salvage the penumbra.
So
So
again, for
again,
collaterals,
for
the conventional
collaterals, the conventional
angiography is still,
angiography is
of
still,
course,
of
the
course,
most the gold
most
standard
the
in
gold standard in
depicting the vessels of the
depicting
brain.
the vessels
But
of the brain. But
because it's invasive in time
because it's invasive in
consuming,
time consuming,
we do not
we
we
do
will
not
not use
we
this.
do not use
The
this.
usual single phase
The usual single
CTA is
phase
also
CTA is
not the
also
one
not the
recommended
one
for
recommended
evaluation of the
for
collateral
evaluation of
status
the
because of
collateral status
its
because of
tendency to
its tendency to
misclassify patients with
misclassify
adequate
patients with
collaterals
adequate
just
collaterals
because
just
it is
because
acquired early in
it
the
is
arterial
acquired
phase and
early in
not
the
all the
arterial phase and
collaterals
not all
has
the
been
collaterals has been
depicted yet. And
depicted
because
yet.
it's single
And
phase, we don't
because it's
have
single
any
phase, we
way of
don't have
knowing
any way of
whether
knowing
there are more
whether
collaterals
there
that
are
would
more
be
collaterals that would be
Siyempre, hindi din
um,
naka-shift.
depicted in the scan.
Kasi hindi
depicted
ko
in
So
the
yung
what
scan.
is
shift eh.
recommended
So
is
what
this
is
multi-phase
recommended is this
CT.
multi-phase
The
CT.
multi-phase
The
CT
multi-phase
that I
CT
am going to show
that I
you
am going to show you
here
here
entails additional
entails additional
scans, post-contrast scans.
scans,
So
post-contrast
the
scans. So
single phase
the
CT,
single phase
we
CT,
usually
we
just do
usually just
one
do one
run of scanning.
run of
But for
scanning.
multi-phase
But for
CT, we
multi-phase
have two
CT,
additional
we have
scans
two
so
additional
that we can
scans
better
so that we can
assess
better
the
assess
collateral.
the collateral.
And
And
there is a particular
there
way
is
which
a
I will not
particular way which I
anymore
will not
expound
anymore
on in
expound on
scoring
in
the
scoring the
collateral status in
collateral
which
status in
um,
which
there would be
there would
still
be
benefit
still
if you have
benefit
higher
if you have
score,
higher
would
score,
still benefit from
would still benefit
recanalization.
from
So as you
recanalization.
can
So
see,
as you can see,
patients with good
patients with
collaterals,
good collaterals,
okay, even
okay,
if the
even
affectation
if the
or the affected
affectation
vessel
or the
are large
affected
vessel,
vessel are
all of
large vessel,
these
all of
has
these
large vessel
has
involvement.
large vessel involvement.
But because they have good
But because they have
collaterals,
good
it
collaterals, it
they would
they would
usually also
usually
present
also
with
present
smaller
with
cores,
smaller cores,
okay, compared
okay,
to those with
compared to
intermediate
those with
and poor
intermediate and
collaterals.
poor collaterals.
So
So
that would be
that would be
my last slide
my last
for
slide for
ischemic
ischemic
stroke imaging
stroke imaging
evaluation. And
evaluation.
we have to
And we
remember
have to
that, of
remember
course,
that, of course,
um, we are
um,
following the
we are
concept of
following
time
the
is brain,
concept
the
of time
importance
is
of
brain, the
time
importance of time
um, in
um,
treating this
in
patient, but
treating this
also
patient. But
we
also we
are gearing
are
towards
gearing
physiologic
towards
imaging
physiologic
and
imaging and
knowing the
knowing the
individual physiology
individual
that may
physiology
also guide
that
us
may
in
also guide us in
treating this
treating
stroke
this
patient.
stroke
And so with
patients.
that, I
And
end
so
my
with that, I
lecture.
end my lecture.
Again, I would like to
Again, I would like to
thank the
thank the
audience for
audience
your
for
attention and the
your
Stroke
attention
Society
and the
of the
Stroke
Philippines for
Society of the
this
Philippines
opportunity.
for this
Thank
opportunity. Thank
Thank you
Thank
so
you so
much,
much,
Dr.
Dr.
Irma,
Irma,
for
and
your
for your
lecture. And
lecture and
speaking with
speaking with
me,
me
Active
on active
Ischemic
ischemic
Stroke.
stroke. So,
So, for
for
our
our
dear
dear
participants, or
participants, or
doctors and
doctors and
nurses, and
nurses,
all
and
of
all of
the
the
healthcare
healthcare
professionals of
professionals of our
Perpetual Health
Bethlehem
Medical
Medical
Center.
Center,
So,
so
we will
we will
have a
have a
30-minute
30-minute
lunch
lunch
break
break
po before
before
we
we
proceed
proceed
with our
with our
afternoon
afternoon
session.
session.
So
So
please
please
have
have
your
your
lunch po.
lunch.
We will
We
have
will
our
have our
individual
individual
lunch
lunch
in our
in our
respective
respective
areas.
areas.
And
And
please be
please be
back
back
home
home
after
after
30
30
minutes.
minutes.
Thank
Thank
you.
you.
Grabe naman, 30 minutes. Galing naman, 30 minutes. Kaya military tayo. Ang lilit matata ko.